All right, welcome everybody. Whoa, to Grand Rounds, and hopefully the beginning of spring. I think the weekend is supposed to warm up and be quite nice. Thank you everybody who is showing up in person. Delighted today to have a very special guest speaker from Alabama. The weather is exactly like this all year round. And introducing our speaker is Dr. Maniba Nazif from the Division of Hematology Oncology. And Maniba, you're pulling up the intro. Excellent. As we're going, thank you.
Hello, good morning. Oh, wow, yeah, it's very loud. So it is my great pleasure to introduce today's speaker, Dr. Julie Kanter. Wow, there's a lot of things to say about her, so I'll try to make it short. She's saying to make it short. Dr. Kanter is a professor of medicine in the Hematology Oncology Division at the University of Alabama at Birmingham, where she serves as the director of the Adult Sickle Cell Disease Program and the co-director of the Lifespan Comprehensive Sickle Cell Disease Research Center. She received her medical degree from Tulane University and went to complete her fellowship training in pediatric hem-onc from Wash U. With a career spanning over 2 decades, Dr. Kanter is internationally recognized for her leadership in the field. Her work bridges clinical care, cutting-edge research, and health policy with a focus on improving access, quality, and innovation in sickle cell therapeutics. She has been at the forefront of efforts to define comprehensive care models and is also a pioneer in gene therapy, leading several groundbreaking trials aimed at developing curative and transformative treatments for sickle cell disease. Dr. Kanter has served in key leadership roles, including the president of the National Alliance for Sickle Cell Centers, and sits on numerous national committees as well. That includes the American Society of Hematology. She's a sought-after speaker and educator, having delivered keynote and preliminary lectures at top institutions and international conferences. And she has authored more than 100 peer-reviewed papers. So today she'll be speaking on how gene therapy saves sickle cell disease, but it is not what you think. I just want to acknowledge the fact that this talk is supported by a generous donation from the Kathy Mosher Philanthropic Grant for Excellence in Sickle Cell Disease, and we really appreciate that. So please join me in giving Dr. Kanter a warm welcome.
Thank you very much for that introduction. It was not short, but we'll work on that. And thank you very much for having me today. My cousin actually went to college here, and so I texted her when I got to the airport, and she told me all the places I needed to go have a beer. Said I didn't think that was on the agenda, but I would do my best. So I am going to talk about gene therapy and hopefully have you think about things a little bit differently. And I like to use gene therapy because it's the hottest new toy on the market, the hottest topic. I also have several conflicts. None of those are going to be relevant to the discussion today. So hopefully at the end of this, we'll be able to talk a little bit about pathophysiology. I'll try not to put anyone to sleep. I have a new analogy that I like to share. Anyone who's heard me talk before, I speak a lot in analogies because I think it helps bring the point home for people who aren't as familiar with sickle cell disease and aren't as familiar with gene therapy. And then it's a way that I actually use to talk about things with my patients as well. We'll talk about the FDA-approved gene therapies. Most people have heard about these. I like to compare them head to head so you can look at some of the differences. We'll talk about some of the barriers and facilitators, highlighting barriers to commercial use. And then we'll talk about how we're going to use gene therapy to really improve outcomes for everyone living with sickle cell disease. Hopefully you can recognize this quote, but let's start at the beginning because it's a very good place to start. All right, good job. So normal hemoglobin is made on chromosome 11. I always bring this up when we think about gene therapy because this is the normal beta globin production. However, we're not going to talk about this because actually all of our current gene therapies don't affect this mutation on chromosome 11. So we think about it as, wow, this is this monogenic disorder. That's why we've targeted sickle cell disease, and yet we're not targeting this mutation. So quick reminder, hemoglobin is probably one of the most important proteins in the body. I'm sure that you can all argue with me on that one. However, without hemoglobin, you don't deliver oxygen, and then none of the other proteins work. But hemoglobin's pretty cool, right? It works to know when to pick up oxygen and when to drop it off. So here's my favorite hemoglobin analogy these days. Might change it again. I like to think about the red blood cell as a car. Job of a car is to drop off its passengers. The job of the red cell is to drop off its oxygen. Hemoglobin, I used to try to explain it as the seats of the car, but I have found it's easier to explain based on the wheels. So in sickle cell disease, the wheels don't quite fit the car, right? They kind of fit, they work enough, but not great. So sometimes they break down in the middle of the street, sending parts of the car everywhere. Sometimes the wheels allow them to get where they're going, but then they can't get to the next place that they're going. And so this is important because if the car doesn't deliver the oxygen, right, the tissue doesn't get the oxygen. Passengers don't get where they're going. This is also important when you think about the pathophysiology of the disease, because what we think about as just a red cell problem is not remotely just a red cell problem. And in fact, it's about how the red cells interact in the environment and how they damage the blood vessels. So again, going back to the car, it's not just about the car, but how the car affects the road. And the more times you have accidents on the road, the more the road gets damaged. So over time, even if the cars are working, even if they're just kind of spitting off a tire now and again, they're going to slowly damage the roads. The other thing to think about hemoglobin, and this is something that I still can't totally conceptualize, is there's so much of it in every red cell. I think I pictured it because of how we learn about biochemistry as, oh, 4 hemoglobin molecules per red cell, right? No, there's millions. So when you picture hemoglobin, I think of it as a bunch of ropes because it helps me understand the idea of polymerization. So instead of these ropes each individually coiling up and doing what they're supposed to do, they get all tangled, right? That's how we think about sickle cell disease, is the cells, the hemoglobin gets all tangled and it makes the cell turn to a funny shape. So why do we talk about sickle cell disease at all, much less for gene therapy? Well, it is truly a multi-system disorder. Unfortunately, sickle cell disease affects every organ in the body. One of my favorite stories to tell is when I first got to my current institution at University of Alabama. At Birmingham, we had an individual with sickle cell who'd gotten shot and was admitted to the trauma surgery. And I called them and said, hey, I need to talk to you. And they were kind of like, we didn't call you. I said, I know, but we got to talk about the blood that you gave the patient because it wasn't matched for someone with sickle cell disease. And the surgeon was still kind of like, yep, still didn't call you. And I said, so downstream, this person's going to have X, Y, Z, and they're going to increase their length of stay and come back with more. Oh, who are you? Right? So understanding that no matter what our patients come into the hospital with, their sickle cell disease remains important and something we have to at least consider when we're developing therapies for them. And we know that the hallmark of this disease is vaso-occlusive crisis and pain. And it's the primary reason for which sickle cell disease gets attention and people seek care. But even without pain, this can be an issue because even without pain, if those cars aren't delivering their oxygen where they're supposed to, or they're just wrecking on the road, we're going to have more and more problems downstream. So long-term, sickle cell really becomes a vascular condition. And it's easier to think about the end organ complications if you think of it as a vascular disease in some ways more than as a blood disease. Why else do we think about sickle cell disease? Well, we've made remarkable improvements, mostly with early interventions, newborn screening, the use of penicillin, the identification of splenic sequestration, our ability to tell individuals who are young, you know, if you're having XYZ, you need to come and seek care. So I had a very colicky baby. I couldn't imagine having a colicky sickle cell baby because I would have been in the ER every other night with my crying, inconsolable child. But at the same time, knowing those things has helped us protect those individuals from dying young. And that's something very different in the United States. So these graphs are a compilation actually of different data sets. And what they show you is that in the 1970s, we had a huge amount of children still dying before they were 10 years of age. It's also why we overuse opioids, but we'll get to that later. We just figured if they were going to die, we might as well let them die not in pain. We just haven't changed our practice sufficiently as time has gone on. And that's why you actually see what you see now, which is that in 2006, it looks like our outcomes were actually slightly better when you look at the age and frequency of mortality than they were in 2014, and that's true. And that actually goes back to opioids and our overuse of opioids, which puts more and more people in the hospital over time. Doesn't mean you shouldn't use them. It should mean you consider how we use them and really trying to use opioids more for acute care and less for chronic care where it's having less outcome. This also gives me a good chance to tell you that this data is mostly geared from the CDC Sickle Cell Disease Data Collection Program. I call that out right now because, oh, by the way, the CDC has no blood disorders program. It just got cut last week. Everybody went home. And so right now, this is on the chopping block. And it is really the reason we know so much more about sickle cell now than we did 2 years ago and 4 years before that. And we are desperately fighting. So just calling that out because this is one of my many soapboxes. So what do we do right now for sickle cell disease? Without question, standard of care is hydroxyurea. You don't get to walk into our centers without us talking about hydroxyurea. Even if you don't want it, I'm still going to say, well, here's why we should think about hydroxyurea. And then chronic transfusion. So really well done matched red cell transfusion is still instrumental, specifically for preventing primary and secondary stroke for people who are at risk, but also for those individuals who have had recurrent acute chest syndrome and a couple of other complications. So still very, very key. Then we have these other novel therapies, voxelotor, which we no longer have because it was withdrawn from the market a couple of years after it was approved, was a hemoglobin modifier. And I think the use and then non-use of voxelotor long-term is actually going to teach us both how to do better in the regulatory world. I hope, well, if there is a regulatory world, we can talk about that too, but also a little bit more about the disease than I think we understood before. L-glutamine, so L-glutamine helps basically supply the red cell with more nitric oxide, and it's an anti-inflammatory agent. It is not the L-glutamine that you're going to buy at the health store. It is pharmacy grade. And then crizanlizumab, which is a p-selectin inhibitor. I like to, when I go back to my analogy of the red cell, I like to say that, you know, once the cars break down, what happens? You get a bunch of garbage trucks and tow trucks, and then when you get all of that, you get more traffic. The more traffic, the more vaso-occlusion, the more traffic jams. Crizanlizumab takes up all the garbage cans, so there's less garbage trucks on the street. It blocks p-selectin, so it actually makes for an easier passageway, kind of how I describe it to individuals who live with the disease. And then we actually have numerous new agents that are being studied, some of which I think are incredibly exciting. We, of course, have all our supportive measures, pain management, diet, hydration, and mental health treatment, which we never have enough of. There is so much anxiety and PTSD in individuals with sickle cell disease, worried about that next crisis, fearful when they stub their toe and they have pain. Their next thought is, what if it becomes a crisis? And if we don't start addressing that in a more regulated, variable, and accessible way, we're going to not make as much headway as we should. And of course, that's my Xing out of voxelotor, but seems to have gotten mixed up. So why gene therapy? So I'm going to reference a couple of different papers. This is still one of the most formative papers in transplant. This was Mark Walter's paper. And interestingly, I only realized this recently. The first bone marrow transplant in sickle cell disease was a child with AML. That child was actually at UAB. That's the part I didn't know. Ended up at St. Jude's for their transplant. Lo and behold, it cured both their AML and their sickle cell disease. And that's where this idea came from. But of course, if you really think about it, it's kind of the original gene therapy. What are we doing? We're just using stem cells to deliver a healthy hemoglobin gene. And in this original paper, it had 22 children, less than 16. Originally, they had a lot of graft rejection. When we added ATG to this regimen, they did very well. And these days, if you're under 16 years of age, we have an event-free survival around 95%, with a match-related donor transplant. So still, if you're going to think about what we call curative therapies, this is going to be your first line. When we think about gene therapy, a lot of the patients who come in, and I laugh because they've heard about it as a one-time treatment. I want the cure. I want that one-time therapy. It's a one-time therapy that takes about a year. And this is something that is really important for everyone to understand. It's not fast. So what happens? Well, thanks to actually one of the companies that we've worked with over time, and I really call out Bluebird Bio for their dedication to people with sickle cell disease, because in the beginning, we didn't do a very good job, and this didn't work very well. And so if you actually look back, they could have said, forget this, it's working in thalassemia, it's not working in sickle cell, but they didn't. And so I call that out as here's where pharma can be our partners and really help improve outcomes. And thanks to them, this is now the process all the gene therapies use, and it was really developed by them. So we recognize that people's bone marrow is hyperactive in sickle cell disease, and so we needed to calm it down. So they get a couple of months of transfusion, which really helps calm down the marrow. Then they can come in, and you have to stop the hydroxyurea because, of course, you want stem cells, so you won't want to decrease their production. That's no small feat. Stopping hydroxyurea can be dangerous, so it needs to be done in collaboration with a hematologist. And then they come into the hospital, they get plerixafor. We can't use GCSF to mobilize in sickle cell disease because it causes all the garbage trucks, all the neutrophils to come out, and they will have the most severe crisis you've ever seen. So we use plerixafor instead, gets the cells out, collect them, we send them off to the lab. When those cells are ready and the stars align, we bring those individuals back in. They get chemotherapy that is myeloablative with busulfan. They hang out in the hospital. They get their new cells. They hang out a little bit longer, getting transfusions and a lot of pain medicine for the worst mucositis you've ever seen. Almost everyone has fevers and requires antibiotics. As we wait on engraftment, once they engraft, they actually do pretty well. So a lot of the work in gene therapy compared to transplant is kind of on the front side. It's actually before they get the cells, the process of getting the cells and getting it into them. Once they get the cells, there's no risk of graft versus host disease. It's their cells, it's autologous cells. So that actually means that their post-treatment, post-transplant treatment is much easier than the allogeneic setting. They're in very long-term follow-up, so a total of about 15 years. When you sign consent, I'm like, so you're signing your life to me, no worries. So we have 2 approved therapies. They have very long names, so I call them Exacel and as opposed to exagammaglomagene, and Lovacel, and I'm not going to try to say that one either. And I'm going to talk about the 2 main papers that we wrote on Lovacel and the gene therapy process. So Lovacel is a one-time ex vivo lentiviral gene therapy. What it does is adds a new gene into the stem cells to make beta globin. Importantly, again, this new gene, this beta globin gene, does not touch chromosome 11, or at least not intentionally, meaning that it can go into other areas, and we actually target it for where it goes within the stem cells so that it doesn't cause a novel, obviously, leukemia or other problem. But it's not changing that mistaken hemoglobin S gene. So these individuals, although they're getting a corrected gene, we're not changing, targeting, or removing the sickle gene. So when we look at the outcomes here, all of these individuals are going to continue to make hemoglobin S because we haven't changed to that. So now they're making hemoglobin A, and it's marked with T87Q. Technically, that slight mutation to hemoglobin A makes it less sickling. It makes it a little bit different and won't polymerize as easily. Mostly, it just allows us to differentiate it on an electrophoresis from regular hemoglobin A. So when we look biologically over time, and now we've had well over 5 years, we have people as far as 8 and 9 years out on this therapy, you can see pretty impressive results. We're getting an average hemoglobin A of about 40 to 45%. So in some cases, I have now patients as high as having hemoglobin A of 50 to 55%. So they do very, very well biologically. And you would think that this would mean that they're cured. I'm going to tell you why they're not in a minute. And by technicalities, 86% achieved globin response. That's this very complicated definition in the fine print that you don't want to know because it's that complicated. But it's very, very durable. We now have many, many years out, and we can feel very satisfied to say that this isn't going anywhere. We don't have to worry that these stem cells have been altered. Now, there are individuals who've had stroke on this trial, and that's one of the differences with the other trial, who have not ever had a recurrent stroke, but they didn't have severe vasculopathy. So what does the FDA want to know? Well, the FDA said, that's great, but biology is not important to us. We want to know what's happening to vaso-occlusive crisis, right? If you're not going to fix pain crisis, who cares? We could argue that point till tomorrow. We haven't won the argument yet. So now when you look at gene therapy, you're going to see a zillion of these swimmer plots that were developed because it's very hard to show this. I'm going to orient you to this graph just in case you haven't seen it. The y-axis is actually each of those people as an individual patient, and the dots across time are their vaso-occlusive crises. So the dots before are before they got treatment with gene therapy. Where there's no dots after, as we move horizontally, the x-axis is time, that's post-gene therapy. That blue box was the designated evaluation period. So one of the things that we note, if you've ever taken someone through gene therapy or any transplant with sickle cell disease, you'll learn that the first 6 months after they get their transplant, they have no crises. You could give them their own cells back with no alterations, and they'll have no crises. Why? You ablate their immune system. So it turns out when you empty the streets of the garbage trucks, the tow trucks, and all the rest of the traffic, it doesn't really matter if the cells break down or crash because they still actually will get enough oxygen where they're going that they won't have a crisis. So there's a huge part of this disease that's inflammatory based. But it also meant, and we had lots of arguments when we developed this, that you couldn't start counting their vaso-occlusive-free time before you got to 6 months. It was sort of cheating. So we were very clear in that when we defined these endpoints. So that those blue boxes are the technical for this specific therapy. That's the evaluation period that we're looking at. But you can see many individuals have had long-term periods. You can also see there's a 1 or 2 individuals with some red dots in there. So even after therapy, they're still having vaso-occlusive crisis or what we call vaso-occlusive crisis. What do we call a vaso-occlusive crisis? Pain that we can't otherwise understand or interpret or has no other clear designated beginning. So they're having pain. I'm not really clear. In fact, I'm really clear that it's not truly vaso-occlusive. And if we have time, we'll talk about that. Suffice to say, though, the outcomes are fantastic. Resolution of severe vaso-occlusive events was 95% in this study, and they did very well. We're going to switch now to Exocel. Again, very long name that I don't do a very good job of discussing. Here we're working on a slightly different premise. So before we talked about using a viral vector to introduce a new gene. Now we're actually talking about gene editing using CRISPR-Cas9. The BCL11A gene is on chromosome 2. It makes this oversimplified mechanism here that you can see that actually alters how fetal hemoglobin is produced. Normally, the role of BCL11A is to turn off the production of fetal hemoglobin. That's how it works normally in the body. When we edit it, we're actually editing chromosome 2. We're editing BCL11A complex. Again, not editing chromosome 11. And that allows fetal hemoglobin to be turned back on. But again, doesn't affect that downstream beta globin, which in this case is the hemoglobin S. So you're still going to make hemoglobin S. So what did we see biologically with this? We see excellent response, durable increases in hemoglobin F with the Exocel therapy. What you're seeing on these graphs, on the top graph is your y-axis is grams of hemoglobin, and the green bar, and it's hard to differentiate. The green bar, which is the top bar, is total hemoglobin, and the blue bar right below it, going horizontally, is fetal hemoglobin. And again, the x-axis here is over time. There are very few individuals who are very far out of this therapy. In fact, when it was approved, only 3 were in the group that were approved over 2 years out, which is interesting. When you go down to that bottom graph, we're looking at the percent of F of total hemoglobin. So again, looks very promising. Our percent F is about 40%, means they do still have about 55% of hemoglobin S, but we are seeing very clinical, meaningful outcomes. Again, putting biology to the side, let's talk about pain. Same swimmer's plot, same exact idea, participants on the y-axis, time on the x-axis. Instead of red dots, you get blue dots for vaso-occlusive crises, and you can see a significant change after Exocel infusion. What's different in this trial, and it's easier to show you here, is there's no clear evaluation window. So I showed you in the Lovo-cel trial how that time from 6 to 18 months was the key window in which we calculated vaso-occlusive crisis events. In this trial, it's any shifting 12-month window post-infusion. If you get 12 months of vaso-occlusive free events, you're golden, you're counted as 100%. You figured that out. So 98% achieve freedom from vaso-occlusive crisis in at least a continuous 12-month period. So now we're going to compare these trials. Hopefully we'll eventually get this paper out on this, where we really looked head to head at these different trials and said, let's try to break this down and understand it. Some very important points. First is age. In the Lovo-cel trial, individuals could be, well, originally only 18 and up, but then down to 12 and now down to 2. But importantly, the outer limit was 50 years of age, so much older. Whereas in the Exocel trial, it was 12 to 35, slightly younger population. When we looked at the mechanism of action, we already talked about that. The mechanism of action is clearly different. One is gene addition and one is gene editing. And when we looked at inclusion criteria, which I seem to not have my star today, you can actually see that chronic pain was an exclusion criteria on the Exocel side, but not the Lovo-cel side. As I mentioned, that primary outcome is slightly different. still 12 months vaso-occlusive crisis free, but one is predefined and one is not. So just some things to think about. Moving along, when we compare the outcomes, unsurprisingly, the group getting lovo-cel is slightly older because they had a slightly older age limit availability. We also saw pretty similar outcomes in terms of the number of hemoglobin SS versus hemoglobin S beta 0, just see more individuals in this country with SS disease. But when you see a difference, it's in the number of vaso-occlusive crises before therapy and again, that age and enrollment. Finally, the stroke history is different. Individuals in the beginning of lovo-cel, when we first started those therapies, people with stroke, which have always been considered our most severe population, were allowed to enroll in the therapy. That changed over time because everybody became terrified that if someone had a stroke, that would be the end of gene therapy. So they stopped allowing the most severe individuals when it became a vaso-occlusive crisis therapy. This is very different than stem cell transplant. When you look at all the original stem cell transplant trials, especially in children with sickle cell disease, the main group that were enrolled on those trials were at risk of stroke by abnormal TCD or sickle stroke screen, or had had a stroke, and this was for secondary stroke prevention. So there's a lot of people who like to compare the outcomes, but they're very different groups of people who are in these trials in the stem cell transplant who are high stroke risk versus this patient who is a high vaso-occlusive crisis risk. And as I mentioned, we did have some individuals in the trials for lovo-cel that did have a stroke. Now, they couldn't have severe vasculopathy, such as moyamoya disease. That was one of the exclusion criteria, but it's not going to be remotely statistically significant. We haven't seen stroke recurrence, which is important. So now let's compare a little bit more. One thing we have learned is that individuals who are getting this CRISPR-Cas9, what we have seen is that it's harder to manufacture those cells. For whatever reason, during that manufacturing process, they lose a lot more of the stem cells. So that meant that they required more times to come into the hospital and get those stem cells collected. So while the median number of cycles is 2 in each group at that top line, you can see that outer range for exa-cel is that some individuals had to come in 6 times to get 6 cycles of stem cell collection. That's going to play a huge role as life goes on because that's expensive, right? Every one of those hospital admissions for stem cell collection ranges from anywhere from $50,000 to $150,000, and that's if there's no complications. Cell dose is also different because if you're able to get more cells, you're able to get more cells. So we see higher cell doses in the lovo-cel group. And of course, duration of therapy at the time of approval was very different, where we had a longer number of people who'd received lovo-cel than those who'd received exa-cel. So there's some significant differences to think about. So then how do we define success? The FDA defined it by vaso-occlusive crisis. But is that really the definition that we're going to use, and can we do better than that? Pain is the most nebulous endpoint we could ever choose for a trial. My friend Dr. Heaney at Boston Children's gave this great example. He said, you know, a vaso-occlusive crisis is severe if the 13-year-old just broke up with her boyfriend. Oh my God, worst crisis she's ever had. But if the 13-year-old has a new boyfriend and really wants to go to the party that night, it's not so bad, Mom, I'll be fine, right? Pain is so emotionally changed based on the state, based on where you're living. You can imagine if you had a vaso-occlusive crisis in a comfortable house, you could probably manage it at home. If it's Wisconsin and you don't have any electricity and it's real cold in January, you're going to believe you're going to go to the hospital for that vaso-occlusive crisis. So yet that's what we're using as an endpoint. It's an incredibly subjective, highly variable and heterogeneous endpoint. So how can we do better? Well, can we quantify this new hemoglobin to prevent sickling? Not just how much, but how it's packaged. So how much new hemoglobin, whether it's A or F, is in every single red cell. Again, going back to my analogy, how many tires did I fix on the car? Did I replace all 4 tires, or did I only replace 3 of the 4 tires? Do some cars have no new tires and they're still hemoglobin S tires? The answer is yes. That's important because we've seen that if you put these cells in a container and measure the point of sickling based on where they sickle when exposed to hypoxia, sickle cell has hemoglobin SS has a very specific, very consistent point of sickling of those red cells. You and I, who have hemoglobin A, you're never going to make our cells sickle. Doesn't matter how hypoxic you make that chamber. Hemoglobin AS, or trait, they do sickle if you make that chamber hypoxic enough. That's a topic for another day. However, What we see in these individuals, and it's not my data to share or to publish other than to explain it, is that their point of sickling is slightly between the severity of SS disease and trait. They're not quite as good as sickle cell trait. What does that mean? It means technically they really shouldn't be climbing Mount Everest. Well, it turns out one of the individuals who got gene therapy actually did climb Mount Everest. Or I think it was Mount Everest. And in talking to him and trying to explain this and having him explain it to other people, he presents nationally all the time. This is not new. He actually says, yeah, at about, I don't know, 10,000, 15,000 feet, my eyes turned yellow and I got short of breath. So thankfully there was a physician on the trip who stuck him on some oxygen and they took it a lot slower. Now, of course, real smart would have been turn around and go back down the mountain. I wasn't there, I can't say anything. He made it up the mountain and he was fine. And now he's gonna do it again, which I'm not so psyched about. But again, really important to recognize this is not quite cured. And that's why I say it's not quite cured. These cells can be more easily stressed. Now, if they go on normal everyday behavior, they're not gonna have any problems. So that's one way of thinking about it. Do the cells hemolyze at all? That's another way. What about their rheology? Are they still sticky? Even these CARs, these red cells with hemoglobin SS, even if they never sickle, they're still stickier than the average red cell. So does that change? And as I mentioned, that hypoxic response. And then organ stabilization. How much organ damage post-therapy should we expect? Well, my friends at CIBMTR and other transplant groups, they do a phenomenal job, right, with post-transplant assessments. They did not do a phenomenal job with sickle cell assessments post-transplant. They know about engraftment, they know about GVHD, they know about what meds were used. They never defined well how many vaso-occlusive crises people had. Did they have retinopathy again? Did they have priapism again? Those just weren't endpoints that were included in the analysis. So we didn't actually know when we looked at gene therapy, we didn't really know how to compare that to stem cell transplant. And that's important thinking about downstream, how we're gonna really improve care for everybody living with sickle cell disease. Functional definition. This is how people have thought about it so long. Pain, fatigue, quality of life. These are all different measures of function. And they're measures that are very interesting because many of the current trials want to use quality of life, which does work very slowly. It takes people a long time to feel that their quality of life is better because the anxiety related to what if I have pain, what if I have a problem, takes a long time, if ever, to dissipate. And that anxiety really drives a lot of that quality of life. Also, I have a patient who said, I thought sickle cell disease would fix everything. It didn't fix his ability to find a wife when he got transplanted. And I'm being completely serious. These were, I think he really blamed every problem he had on sickle cell disease. So he had a haplo transplant. He was cured truly of his sickle cell disease, but yet things weren't all better. So we have to wonder what we're measuring at times. Okay, so what we do know is that these gene therapies are remarkable. They really improve outcomes, they transform. They increase total hemoglobin, they increase non-sickle hemoglobin, hemolysis is almost completely resolved, and they decrease or eliminate painful crisis. They improve fatigue and quality of life. Patients generally say they feel better, they think this therapy was amazing. But there's a lot we still don't know before we go around telling everyone we're gonna cure you. We actually have no idea if this is going to protect against long-time stroke or kidney damage. Kidneys are the most hypoxic organ in the body, maybe next to the liver. They could probably argue it out. But both of those organs, specifically the kidneys, we actually know get damaged even in people with sickle cell trait. So could this disease continue to progress in the kidneys? We actually have no idea, and we won't know for a few more years. What about stroke? Is it protective against stroke? We haven't done those trials in the right way yet. What about retinopathy? Can people continue to have retinopathy, or does that completely go away? The eye is such an easy window into our organ systems that we haven't paid enough attention to. And we don't think that these therapies are going to repair damage per se. I don't expect them to make new bone in someone who's had avascular necrosis. But we do know that if you had a 45-year-old male who's enjoyed every meal at McDonald's his whole life and has a heart attack, that if he changes his diet, decides to exercise, gets on some statins, his blood vessels are going to remodel and he's going to have a lower risk of long-term bad cardiac outcomes. Our patients should remodel their blood vessels as well, but is that remodeling the same? Is it not the same? How much time does it take? We just don't know. And at the time of approval, we didn't even know if exa-cel was durable. We still don't completely know it's durable. There's some people smarter than me who feel like mucking with BCL11A is a bad idea and that long-term those stem cells won't continue to be pluripotent? That's a question for another day and another time, but I think it's an interesting question. So how else can we measure the effect? Well, I mentioned we can measure the amount of the healthy hemoglobin, we can measure how many cars have new tires, not just how many new tires are there. We can measure how effective those cells are at delivering oxygen, and we can measure overall, again, looking at each red cell through really cool single cell Western blots, we can actually measure the percent of the cars with new tires. Because if you think about what an electrophoresis does, it's like you took a bunch of cars and took off all the tires and put them all in a bowl and counted them. That's not telling you tires per car. That's just telling you total cars and total tires. So we really want to know how many actual red cells are sufficiently fixed to not sickle. So that's why we say these are transformative. There's just too many things we don't know. And this is a patient population where exaggerating is not going to be to our benefit in the long term. So if I tell someone they're cured and one person has a stroke 3 years later, you can only imagine that people are going to come back and say, you lied. You didn't tell us the truth. So we have to be very careful in our language. And this is a patient population that's been continuously injured and beat up in a number of ways. The most recent, unfortunately, being the withdrawal of the drug voxelotor. That company did a phenomenal job in marketing this drug. So to have it withdrawn was a real gut punch for this community. So I think it's especially important now that we are careful in our language. But they definitely increase health-related quality of life, and they do improve crisis better than any other study we've seen before. Tremendous improvement in hemoglobin, and people feel better. What else do we need to consider? It's an incredibly complex and logistically challenging administration. This is not your run-of-the-mill allo stem cell transplant. And for my transplanters in the room, love you guys, but if I asked you to make my Porsche into a minivan or vice versa, you would. You would say, yeah, I can transplant that. Yes, I've worked with a lot of transplanters, and I see all of you all smiling and laughing because you know it's true. However, we have to be very cautious in the management of these individuals because they're not just a myeloma patient coming in for an autologous transplant. It's a very different setup. Infertility remains a clear known risk due to myeloablative conditioning. There's obviously the cost factor. These current therapies are priced at $2 and $3 million respectively. Mind you, that's just the price of the cells, not the price to get the cells, not the price to do the transplant, not the price, you get the point, just the cells. And there's still question over long-term safety and malignancy risk. Okay, so that brings me to the real discussion. So then you've told us all about the gene therapies, that's great, but how does this help people who aren't going to get them? Because at $2 and $3 million a pop, and I talk to these investors in the world, and they're like, why aren't more people getting this? How many people do you think will get treated next year? And I'm like, I don't know, maybe 20. They're like, percent? No, 20 people. And in fact, in this past year, one single individual, despite the approval of 2 commercial therapies, one person in 2024 was able to actually successfully get one of the commercial therapies. Now, there's a lot of people in the runway, and it's slowly getting there, but it's going to be a long time till we talk about that 5% of people have been treated. So we have to think about who administers gene therapy. As I mentioned, this is not your run-of-the-mill stem cell transplant. So there's an urgent need for sickle cell disease and transplant experts to work together to define what a transplant center or what we're calling a transformative therapy center should look like. Currently, the companies have defined it, and the definitions that they use are not going to be what the specialists in the field use. So the companies that deliver these therapies have defined an authorized treatment center or a qualified treatment center, ATC or QTC, mostly based on whether they have the technical abilities to safely take the stem cells, send them off, get them back, and put them in the patient. They're not seeing if this stem cell transplant physician has ever transplanted somebody with sickle cell disease. They're not even looking at whether the hospital generally sees individuals with sickle cell disease. There's one hospital, won't completely call them out, in Florida that doesn't take Medicaid. That you can imagine they probably don't see that much sickle cell disease, but they're a qualified treatment center. To their credit, they knew very well that they didn't have the knowledge they needed and actually developed a sickle cell center so that they could develop the knowledge they needed, but not everyone goes above and beyond that way. So we said, okay, there's got to be guidance. We have to lay some ground rules for who can do this therapy, because it's not just about fixing the cells. How do you take this person who's been sick their whole life and make them not sick? That's actually incredibly complicated. And that even though these are one-time treatments, they take a year. So what is your hospital scared of? and this actually happened sort of to us recently, your hospital's scared. What if you make that stem cell product, your hospital's paid $3 million for that product, they're waiting on that reimbursement, and that patient gets in a car accident and doesn't survive? You're out $3 million because guess what? Insurance is not reimbursing for cells that aren't given to a patient. So you can imagine that keeping these individuals healthy through this entire process is important. And when we think about the current model of care, it's very, very fragmented. It's why we don't have great knowledge of outcomes from stem cell transplant. We just haven't done due diligence along the way. So the sickle cell disease teams are usually taking care of those individuals for a very long time, from birth through adulthood, if all goes well. And then they hand them over to the transplant team. And sometimes they never, more often than not, they never came back to the sickle cell team. And if they're 100% fine, that's great, except what if they're not getting their eyes checked or their iron chelated or some of the other things that we still know need to happen? And so we said we have to have multidisciplinary care throughout this whole process, before, during, and after therapy. And there's this, as I mentioned, huge in-between time between when those stem cells are collected to when they're given back to the patient. In the clinical trial sort of timeline, it's about 3 months. In the real world, in commercial therapy, it's actually anywhere from 2 to 8 months that there could be a lag because of all the production issues and whatnot. So how do you keep that person healthy during that interim time? What do you do to make sure that they're ready? And then how do we make sure individuals actually get to where they need to be? This is my Hamilton slide. Are we a nation of states? What's the state of our nation? It really applies right now, but there hadn't been for a long time. We are not oncology in the sickle cell disease world. We don't have SWOG or COG or any of the other working groups. So we don't have these collaborative efforts that have helped define what practice harmonization should be. And we needed to change that when we get into the world of gene therapy. There were these intermittent consortiums. There were sickle cell center consortium from the NIH, but when funding ran out, those all dissolved. And so we had all these competing policies and competing consortiums, and then no one would share data because then everybody was worried they wouldn't get the next grant. So we had no national sickle cell disease registry, and we had no cooperative approach to quality improvement. So as we started to see gene therapy was going to work, a couple of us got together and formed the National Alliance of Sickle Cell Centers. We had nothing better to do in 2020. I hear it was a time of ease in the country. So why not? So we said, let's get together and form a group that's actually dedicated to people living with sickle cell disease, to say, we're going to support the centers. We're going to define what a center should look like. There was no great requirement for what you needed to be. I mean, anybody could hang a shingle outside and be like, woohoo, I'm a sickle cell center. So we needed to make sure that we had that well defined. And then we had to advocate to get people the resources they need. And the real goal is to ensure that every person in this country living with sickle cell could see a sickle cell specialist. Again, sounds obvious, but you'd be amazed at the number of individuals who've never seen a sickle cell specialist, who've never even seen a hematologist. And we now have 121 recognized centers in the United States, which people thought was never going to happen. Then we said, okay, great. We've recognized centers. We've identified what it takes to be a sickle cell center, but we need to work together. And I mean, if you've ever gotten a bunch of hematologists in the room and talk about an echo and how often they should get an echo, it's one of the most hotly debated discussions you can imagine. It cracks me up every time because I know the people in the call who are going to, well, you know. But anyway, we said, okay, we're going to have to all agree that there's not everything we're going to agree on, and we have to come up with some consensus practice recommendations. So we finally actually just got this paper accepted for publication about the methodology that we're using. It's a modified Delphi method, very well established method. We've modified it for a more hybrid approach and to ensure the voting of every current identified sickle cell center. So we do a literature review, we take a vote, we meet in person once a year, discuss it, come up with a kind of finalized set of standards and recommendations, and then we send it to everybody where every single center gets one vote to measure whether or not this is going to be what we call our recommendations and what we're going to use for practice harmonization. And through this, we also assess barriers to transformative therapies, because if we're going to set some rules, we have to know what the barriers are. So when we looked at the barriers, there was transplant barriers. There were some places that wanted to do gene therapy but didn't have stem cell transplant or weren't FACT accredited. Sickle cell disease, could you find willing patients? How do you get all the resources you need? Social work, mental health support, patient navigator. What about wait times? And then, of course, the hospital administrative staff, often where our biggest barriers lie, financial barriers, limitations of insurance, so huge barriers to getting this therapy to patients. So the Alliance came out and said, well, one of our Delphi projects is going to be who should be a transformative therapy center, because it's interesting. Once you publish it and put it on paper, it's much easier to bring it to your C-suite and say, this is what I need to do this therapy. If it's not published and you bring your list, they're like, who are you, right? But if it's something that's published and it's recommended, that's much easier. So we didn't say who should get gene therapy, but who should be able to deliver the therapy, what processes need to be in place, and who can manage the care pre, during, and post therapy. Came up with two main sort of statements around this. One is that we consider gene therapy transformative, not curative. So I'm constantly correcting language because, again, I think language is important. And when we talk to individuals with sickle cell disease, it's very important that we're not sure this 100% fixes everything. And we need to keep seeing you in our clinics to make sure that we continue to do the screening and do our due diligence. And that transplant for sickle cell disease should involve a team that has experience in caring for individuals with sickle cell, not just transplant, and not just sickle cell without transplant. You have to have both sides. So I'm not going to go through all of these in great detail. I'm going to tell you that you can find them on the website and that we're publishing this as well. But there's some things I'm going to call out that are very important because they go back to why we're going to use gene therapy to help everyone with sickle cell disease. One is having a sickle cell specialist, and two is having a transplant specialist, and three is having them talk to each other consistently, right? Seems pretty easy, maybe. And then having a transplant coordinator who's really dedicated to this. I have a nurse practitioner who serves as my transplant coordinator. She manages 6 a year, 6 patients, that's it. So when I tell my BMT team that, they're like, no, that doesn't work in our models. I know, but that's how much it takes to schedule these individuals because of the timing with red cell exchanges and everything else. And then we said, okay, here's the personnel that you need. As you can imagine, it's a very long list. You need to make sure that you have access to fertility preservation, especially for women. Men, fertility preservation, man, you guys get off easy. Much easier than doing an ovarian tissue harvest or egg harvest. And then we needed to make sure you had psychology and psychiatry. And those were things that not every center had. So putting it on this list meant even if you only did gene therapy for 2 people, now you had a psychologist who was going to see individuals with sickle cell disease. We then said, you got to get your apheresis team in line. They got to get real comfortable with doing not just red cell apheresis, but leukapheresis in people with sickle cell disease. You have to make sure your blood bank is aligned. There's some very talented blood banks who are still not appropriately phenotype matching for sickle cell disease. Well, they shouldn't be doing this therapy then. You have to make sure you have a lab that can do busulfan pharmacokinetics or send them out. And you have to be able to follow those patients. You have to have a plan to follow patients for 15 years. Why was that important? Well, many of the people doing gene therapy were pediatric programs who are transplanting 17-year-olds. So are you still going to see those individuals when they're 30? And what if they have complications? Who is going to help you manage? So you had to have that plan in place. And then the facility resources are I thought fairly obvious, but I was amazed at how many places didn't have in-house hemoglobin electrophoresis, could not quantitate electrophoresis in-house, and that has to be there. So then we put together this really nice sort of a schematic of how we're going to take that process, spread it out, and define who needs to be involved at each step. Understanding that it's a disease that's been managed by hematologists who know these individuals, that they need formal education. So I have a zillion patients who walk in my door and say, I want gene therapy, and they leave with hydroxyurea. Why? Because they were terrified of this, oh my God, chemo agent called hydroxyurea. I'm like, you know the gene therapy needs chemotherapy, and their eyes get bug-eyed, right? No one's ever sat down and really explained it to them. But what's important is they walked in my door. So the other reason that we improve care with gene therapy is because it gets so many more interested patients in the door of a sickle cell specialist to really hear about what they can do to improve their care. And I'm forever amazed at how many people aren't even understanding what a crisis is. What they've been taught is a crisis means they have pain in their body and they have sickle cell disease, not what it is or what really happens. And of course, when you ask about half of these individuals, what do you take for your sickle cell disease? They say oxycodone. And I said, no, for your disease. And they say, yes, oxycodone. And we have to start from the beginning and talk about that oxycodone, great pain medicine, doesn't make your blood flow. So getting individuals to understand so much of this can really translate downstream to better outcomes. We also defined who needs to be part of your multidisciplinary team. Once you get through all the screening and the discussion, you should sit down and have a meeting, make it monthly. You can cancel it if you don't have anyone to discuss. Just say, yes, this patient can go forward. And then making sure you have all multidisciplinary access, including mental health when they're admitted. And then that 15-year follow-up is key. And that's why I highlight it twice. So post-transplant, we also said you should have a transformative therapy clinic, or if you don't have enough patients, you should both see the patients on the same day. It needs to be your transplant physician and your sickle cell physician. And then long-term, we actually say you should follow up with your hematologist because your issues are not transplant related. So in my institution, once they're totally engrafted and don't need any transfusions, essentially they follow up only in the sickle cell center with the exception of the day 100, day 1 year, and then they see transplant because really their needs aren't related to transplant. So how do we improve care then? Well, we believe that more people living with sickle cell disease who've been seeing primary care doctors or just community oncologists are actually walking in the door. Certainly true in my institution. I'm amazed at the number of referrals that I get just because there is this treatment. So they've actually sat down and said, wow, is there someone who does this? It's amazing too that primary care doctors don't realize the world has changed and they're sickle cell specialists in the world. Most of them are very happy to have our help. They just didn't know we existed. We also recognize that many of these people who thought they wanted to do gene therapy and thought it was an easy one-time solution will realize it's probably not an easy one-time solution and want to do something else. I mean, I love when I talk to someone and they're like, well, we go through all the different options for treatment. They're like, well, what's the safest? Hydroxyurea is the safest. We have the most data on. Oh, okay, I'll do that. This is someone who's just never had it really explained to them. And we'll finally have the staff we need to provide care for everyone living with sickle cell disease, including the 1 or 2 people a year who might get this, a psychologist, a social worker, access to a psychiatrist and a care coordinator. And now we have interest from other people who are like, wow, maybe sickle cell's cool. Maybe we want to actually learn about sickle cell and be involved in the care of these individuals. Most importantly, we'll also finally collect longitudinal data, not just on people who get transplant, but for sickle cell disease specifically. We also put together this map. It's actually slightly behind, but we put it available to people where they can find sickle cell centers to get directed to gene therapy centers. But again, we have to have data. We're never going to understand the impact either in individual or population health if we don't have data. Please support your CDC, support AHA if that's where the blood division goes. Wherever it goes, we need our blood division back so that we can track data long term. And we need to really quantify, again, the pre-treatment mortality or morbidity and mortalities and post-treatment, because that's how we're going to say long-term, yes, this is better and it's worth $3 million. Yes, these people aren't in the hospital and look at the money they save. But if we don't do this in a rigorous way, we're not going to have those data. The CIBMTR has started a process to actually collect these data. They do now have sickle cell disease specific case report forms. The issue continues, however, that the CIBMTR starts data collection on day 0 when patients get transplanted. They're not starting clearly at birth, but they're also not starting at before stem cell collection. So that's really important when we think about quantitating both cost as well as morbidities associated with this process. So we also are advocating to use the National Alliances registry called GRANDAD. I didn't name it, it's not my fault. Stands for the Global Research Network for Data and Discovery, and now it's stuck and we can't get rid of it. By the way, we have a trait registry called AUNT, and we have registries in other countries that collect the same data, and they're called cousins. I mean, it doesn't get any better than that. But it is a very, very specific sickle cell disease registry. And if we can link the people from GRANDAD to CIBMTR, you really have a comprehensive data set. So we talked about why we're using gene therapy for sickle cell. We talked about the approved gene therapies and how they work. Nobody fell asleep during pathophysiology. That's awesome. We talked about knowing if gene therapy is working, quantitating that, what the barriers have been so far, and how we can use those resources to really save everybody and improve care for everyone living with sickle cell disease. You should scan that code and do a link to session evaluation. And thank you for your attention. I'm happy to take any questions with whatever time we have left.
Hello, Dan Rosenberg, Immunology. Fantastic talk. So gene therapy is obviously of huge interest to me, but I think one of the problems in immunology specifically is like we have these things, they work, and then getting them to the commercial side, it seems that no pharmaceutical company wants to touch them, and we're doing endless trials, even if they work. Can you speak to some of the barriers that you had to overcome on the business pharmaceutical side to get these things to commercially available?
There's so many barriers. They're going to get better as time goes on. The expense companies have to put in upfront is huge, and so they have to also recoup that funding, which is part of why these are so expensive. The model that they use, so CRISPR-Cas9 is cheaper than lentiviral, so there's certain ways that you can decrease costs, but anything that you can mass produce long term, so the more lentiviral vectors we make, the cheaper it gets. So there's some ways to do that. But it has to be that these companies should identify upfront a partner that's going to commercialize them. So what I mean by that is both Bluebird and then what happened with the other trial with Exocell is CRISPR was the original manufacturer, and then CRISPR the company, not the technique. And then CRISPR actually partnered with Vertex upfront to say, we're going to take this from point A all the way to commercial use. That's been very successful as a model. What didn't work was the company called Editas, who has a successful gene therapy in trial, but they didn't have a commercial partner. So by the time they went to look for one, nobody wanted them. And so it has to be an upfront partnership, as I'm understanding it from the business side. And then one thing I think that the companies both did well and poorly, the first was that they did a great job going to insurers and saying, this is what we're doing, this is what it's going to cost. They went to Medicaid, there's a CMMI gene therapy model that hasn't been X'd yet. And hopefully won't, but right, there are all of these ways of doing that, which was great, except they didn't go to hospital administration and they didn't sit down and talk to administrators about how they wanted this to look. So again, I think that these companies are going to set a pathway in place that will long-term be easier, but right now it's been complicated.
Julie, thank you for a great talk and for your incredible body of work. Annie Marsh with Pediatric Hematology. A couple of questions, I guess. Number one, I'm wondering if you could just briefly comment on the cases of AML and MDS that were seen in the lovo-cel trial and how we navigate those conversations with patients. And as a follow-up to that, sort of, as you well know, when we're sitting in rooms with patients who we've known for a decade or more, they really look to us to help guide some of these decisions. And I'm wondering, when you're sitting in those spaces, thinking about the available transformative therapies that we have with lovo-cel, Exocell, and the possibility of transplant, how do you help them kind of with that decision-making process about which of those potential therapies to pursue?
Those are great questions. So for those who don't know, in the original lovo-cel, we divided into 3 stages. We divided them into group A, group B, and group C. That wasn't the upfront designation. That was actually kind of a post hoc designation. So the first 10 patients that we did with lovo-cel didn't have great results. They had very poor transduction. So when you looked at the number of cells that got that new gene, it was around 20 to 25%. You want that to be as close to 100% as possible. We didn't get a lot of stem cells because we were doing actual bone marrow harvests. You can imagine, by the way, how cool that was, doing bone marrow harvests on people with pain. They really appreciated that. So that was another problem, is we didn't get as many stem cells. And then it turned out that the stem cells we got were poor quality, which is a whole long discussion, but you'll have to just take my word for it. All that to say is we didn't give them a very good product. We didn't know we didn't give them a good product. We didn't mean for that to happen. We recognized it very quickly, and actually only 7 people received that not great product before it was stopped. But 2 of those people went on to cases. It was found to not be the vector, right? The biggest fear was that it was the vector that was causing the problem. It was inserting itself somewhere it wasn't, and it wasn't. The scarier problem is that it turns out we think people with sickle cell disease might be an increased risk for AML at baseline. So when you take some of their cells, manipulate them poorly, put them back into a stressful environment where they just become sickle cell disease, and again, which is essentially what happened to these individuals, that didn't go well. So what I explain to people now is that actually, we don't even use any parts of that process anymore. Yes, it happened. Yes, we have to think about it and worry about it. But at the same time, since we've changed our process, we don't see that. There's one patient who has been diagnosed with MDS using the new process. It's a very convoluted discussion to say that about half the world or 3/4 doesn't think they actually have MDS. But What I now also tell people is there's about a 1 to 2% risk of everybody getting MDS or AML who get an autologous transplant. And that's regardless of whether you have sickle cell or not. That's just the risk. So I try to put all of that into a package that this is a high risk, high reward therapy. It's why I'm not ready to do it in my 2 and 3 and 4-year-olds. It's why I don't think we should yet. However, I think it's incredibly impactful therapy, and we can identify high risk patients early on. When I talk about differences in the different options that are out there, I really don't spend too much time on the lovo-cel versus exa-cel difference. We just don't know enough. All we know though is that if someone comes to you and they're doing great with hydria and they have 20 or 30% fetal already, I say maybe whatever reason fetal's not for you and you need hemoglobin A. I actually personally think hemoglobin A long-term is better than hemoglobin F because that's what we do in nature, right? We all turn on A and off F. There's got to be a good reason for it. F is better than S though. When I talk more about gene therapy versus transplant, a lot of it depends on where they live. How close are they? What's going to be their adherence to post-transplant immune suppression? And those are some of the conversations that I have. And do they want to know what we've been doing for 30 years, which is transplant, where we have more data, at least in terms of safety, or do they want to do what's easier?
Right. We're actually at time, a little bit over. So we're going to end the talk here, but I want to thank Dr. Kanter for her excellent talk and this great discussion. Anyone who has any additional questions in the audience here, she'll be here for a bit, so you guys can certainly pop in to ask more questions. And we did get a lot of online questions as well, but we can.
If you save them and send them to me, I'm happy to answer them.
That's what we'll do.
Yeah.
Yeah, awesome. All right, well, thank you.